surgical oncology at the University of Texas MD Center in Houston, Texas. He additionally was awarded a PhD in molecular and cellular physiology, a master's in education, and a master's in business administration, dual concentration in marketing and management, all from University of Cincinnati. His clinical interest lies in melanoma and soft tissue sarcomas. He's also actively involved in basic science and translational research focusing on signaling mechanism determining cancer cell survival slash stemness and is active in the development of clinical trials. He has a particular interest in surgical education and Luke works to reduce the burden of cancer in his community by working with partners throughout the region. Please join me in welcoming him.
Thank you very much for that very kind introduction, Dr. Amajoy. And thank you for allowing me to host with you this series focused on primary and secondary hepatic malignancies. I think we have an incredible treat today of some phenomenal speakers and a panel to follow, which I think will really highlight the international collaboration and the nature of the International College of Surgeons. So I think we're going to have an amazing next 1 hour. I'm going to go ahead and introduce our first speaker, and we'll have the kind of the structure for today is that we'll have two speakers and then the panel immediately to follow. For those of you who are in the audience, please take the time to put in your questions into the chat function, and that way we'll be able to answer them live as we proceed. And this will, of course, be recorded as well if you miss portions of our discussion. So I have the honor today of introducing our first speaker today, who's Dr. Toru Beppu. Dr. Beppu received his MD and PhD from Kumamoto University. He's a professor in the Department of Surgery at Yamaga City Medical Center and the Department of Gastroenterological Surgery at Kumamoto University in Japan. He's a fellow of the American College of Surgeon and endoscopic, also has an endoscopic surgical skill qualification system. He is the counselor of the Japanese Society of Gastroenterological Surgery, and he's a member of numerous prominent societies, including the Japan Surgical Society, the Japanese Society of Clinical Oncology, and the Japan Society of Hepatology. He is a prolific author, as well as a renowned expert in liver metastases. And for that reason, we have invited Dr. Beppu to discuss the treatment of lobar liver metastases, which, as all of you know, is a challenging condition to treat. So with that, we'll see Dr. Beppu's presentation. Thank you very much, Dr. Beppu.
It's my great honor to join this webinar on colorectal liver metastasis. Thank you, Professor Mamen and Professor Yamamoto, for inviting me. I'm Toru Beppu from the Department of Surgery, Yamaga City Medical Center, and Kumamoto University, Japan. I have no conflicts of interest to declare. Today, I will talk about two topics. The first topic is treatment strategy for colorectal liver mets according to the recurrence risk estimation. Classification of colorectal liver mets according to the resectability is shown. However, distinguish three groups is difficult, and partial overlap can still exist. Our treatment strategy for colorectal liver mets is presented. We perform upfront hepatectomy without ablation for low to moderate risk patients with a BEP score of 10 or smaller. For resectable but high-risk patients with a BEP score of 11 or more, and unresectable patients, we perform induction chemotherapy followed by hepatectomy alone or hepatectomy plus ablation. Risk stratification was performed according to the BEP score. What is a BEP score? Japanese Society for Hepatobiliary Pancreatic Surgery nomogram was created to predict disease-free survival after upfront hepatectomy for 727 patients with colorectal liver mets. The JHPBS nomogram had 6 independent preoperative risk factors with individual points. The score is the total points of the risk factors in the JHPBS nomogram. Among risk factors, tumor number 5 or more is the most prominent 9 points. According to the BEP score, estimated 3-year and 5-year disease-free survival can be instantly calculated. 0 point, 10 point, and 20 points. Borderline resectable is defined as technically resectable but has a high risk of recurrence. The BEP score is 11 or over. In fact, patients with 11 or more BEP scores showed very poor disease-free and overall survival. The median survival time was only 22 months, similar to chemotherapy alone. Progressive disease rates are summarized under the first-line chemotherapy. Recent chemotherapeutic regimens show very low progressive disease rates, which is no more than 8%. From this viewpoint, induction chemotherapy is permissive to achieve for borderline resectable colorectal liver mets. Induction chemotherapy can reduce liver resection rates. Right hepatectomy and left partial resection of 41.2% was changed to multiple partial resections of 18.8%. From our recent paper, limited to high-risk patients, preoperative chemotherapy, green line, can provide better disease-free survival than adjuvant chemotherapy, red line, and hepatectomy alone, blue line. A randomized control trial named Charisma is now ongoing, assessing the utility of preoperative chemotherapy for borderline resectable colorectal liver mets. Registered patients have high-risk colorectal liver mets with 3 or more positive clinical risk scores. The results are awaited to be published. Let's move to the technically unresectable colorectal liver mets. We have recently published international guideline for liver metastasis in the Journal of Hepatobiliary Pancreatic Sciences. The international guideline demonstrated that conversion surgery is weakly recommended for patients with colorectal liver mets. Professor Adam has reported 94 actual 5-year survivors, including 28 real 5-year disease-free survivors after conversion hepatectomy. Our Kumamoto University group also reported that hepatectomy after induction chemotherapy is the most significant prognostic factor and can provide approximately 40 actual 5-year survival. Needless to say, the goal of conversion therapy is not to transform tumors into resectable ones, but to accomplish long-term survival that is cancer-free, treatment-free, and with good quality of life. Second topic is surgical procedure and their result for bilobar colorectal liver mets. In patients with colorectal liver mets, a non-anatomical approach is suitable because tumors are growing in the pro-metastatic niche other than separating along vasculature. So, Parenchymal sparing hepatectomy is essential for bilobar colorectal liver mets. In the international guideline, as a clinical question 3, parenchymal sparing hepatectomy is recommended over major hepatectomy. However, we need to apply surgical specific techniques for some patients to increase resectability, especially for bilobar colorectal liver mets. Various types of two-stage hepatectomy and ARPs are applied. The first large cohort study of the ARPs for colorectal liver mets was demonstrated. It included far advanced patients. However, 5-year cancer-specific survival was relatively high, 33%. This is a very variable RCT comparing the benefits of TSH and ARPs. The resection rate was significantly higher, safety was equivalent, and the interval to two surgeries was shorter in ARPs. Finally, overall survival was significantly longer in ARPs. In contrast, the latest meta-analysis showed equivalent overall and disease-free survivals in two-stage hepatectomy and ARPs. One propensity score matching study showed that parenchymal sparing hepatectomies are associated with lower morbidity and shorter hospital stay compared with other types of surgery. Furthermore, a similar long-term outcome was shown in parenchymal sparing hepatectomies and other surgical procedures. Two-stage hepatectomy and one-stage major hepatectomy with contralateral resection or ablation were compared. Two-stage hepatectomy provides better overall survival and fewer complications than one-stage hepatectomy. Indication of ablation for bilobar colorectal liver mets is shown. Hepatic resection is essential for tumors that exceed indications, but ablation is acceptable for other tumors. Based on a strict criteria, the therapeutic site recurrence rate was 1.6%, and long-term survival was identical in patients undergoing hepatectomy with ablation and hepatectomy alone. A propensity score matching study in Paul Bruce Hospital showed a similar long-term outcome. This propensity score matched study showed that laparoscopic two-stage hepatectomy provides some perioperative advantage, including less blood loss, fewer post-operative complications, shorter hospital stays, earlier induction of chemotherapy, and similar long-term outcome. Now I present two impressive cases. Case 1 is a 62-year-old man with synchronous multiple colorectal liver mets. He had 15 bilateral liver mets in all segments 1 to 8. According to the BEP score of 19 points, if upfront resection was done, the estimated 5-year disease-free survival would be only 2%. Practically, after effective induction chemotherapy, two-stage hepatectomy was successfully completed. Tumor marker levels were over 1,000 before hepatectomy. However, they rapidly decreased within the normal limit. The patient is doing well without any recurrences for over 14 years. Case 2 is a 47-year-old man with rectal cancer and multiple liver metastases. BEP score was high enough at 14 points. CT showed the highly advanced liver metastasis. He has undergone multiple treatments, including surgery, chemotherapy, ablation, and interventional radiology. The patient has been doing good QOL over 4 years. There are no viable regions in the liver. It is a summary of the treatment strategy for bilobar colorectal liver met. For high-risk or unresectable cases, induction chemotherapy followed by hepatic resection is essential. Parenchymal sparing hepatectomy is the first choice. Two-stage hepatectomy, ALPS, ablation, and laparoscopic approach should be selected according to the degree of tumor progression and the surgeon's proficiency. Long-term outcomes was investigated between bilobar and unilobar colorectal liver mets. The worldwide data from liver met survey showed that overall survival was inferior in bilobar colorectal liver mets than in unilobar one. However, it was a univariate analysis. The well-known clinical risk score did not include bilobar spreading as a predictive factor. This large propensity score matching study compares unilobar and bilobar colorectal liver mets. Even after matching, the bilobar group showed a more significant number of tumors. Nevertheless, survival analysis showed no differences according to the distribution of colorectal liver mets. The latest report from the nationwide survey in Japan showed that bilobar distribution does not significantly affect overall survival in the era of multidisciplinary treatment. It is my conclusion of this talk. Even for bilobar colorectal liver mets, a multidisciplinary treatment strategy should be applied according to the recurrence risk estimation. Thank you for your kind attention.
Thank you very much, Dr. Beppu. That was an incredibly thoughtful and insightful discussion. And I know that we'll have some time for further discussion and questions in a moment. Particularly, I'd like to learn more in a few moments about the Beppu score and then your thought process as you're working through these incredibly challenging clinical situations. So I look forward to discussing with you in a few moments. Thank you again for your presentation, Dr. Beppu. We're going to go to our second speaker now, who, for those of you who are International College of Surgeons members, really needs very little introduction. Dr. Sulfas, Georgios Sulfas. Dr. Sulfas received his medical degree from Broward University School of Medicine, and then went on to complete his general surgery residency at the University of Iowa Hospitals and Clinics, and then on to a transplant research fellowship at the Starzl Transplant Institute at the University of Pittsburgh. He then did a 2-year transplant surgery fellowship at the Massachusetts General Hospital, and then joined the Division of Solid Organ Transplantation and Hepatobiliary Surgery at the University of Rochester as an associate professor of surgery. Dr. Sulfas then subsequently moved back to Greece and is currently a professor of surgery and the chief of transplantation surgery at the Aristotelian University of Thessalonica. I mentioned that most of us in the International College of Surgeons know Dr. Sulfas well because he served not only as the president of the Greek chapter of the International College of Surgeons, but also as a world president of the International College of Surgeons, and as also the chair of the International Relations Committee of the American College of Surgeons. He's a member of numerous prominent hepatobiliary surgery organizations, including the HPBA and IHPBA, and has served on numerous committees in those organizations. He's also a prolific author and speaker. And today, Dr. Selfis will be joining us to speak on the role of transplantation for the treatment of hepatocellular carcinoma and colorectal metastases, which is an incredibly exciting and evolving field. So we'll now go to Dr. Selfis's presentation.
Good afternoon. I would like to thank Professor Mann and the U.S. section of the International College of Surgeons for this gracious invitation and the opportunity to participate in what is another excellent webinar organized by the section. Today, I would like to talk to you about the role of orthotopic liver transplantation in the management of hepatocellular carcinoma and metastatic disease from colorectal cancer. The issues that I would like to address is the overall topic of transplant oncology, then specifically about the role of transplant for HCC and liver metastatic disease, and finally a very brief mention of different aspects of technological progress that are affecting this whole discussion. And in between, some pictures from Thessaloniki, which is the second biggest city in Greece, with about 1.5 million people, and hope that you all come and visit. Transplant oncology is, the concept has been present for the last several years, as in the past, transplant was more of a last-ditch solution, or last-ditch effort for patients with cancer that were very extreme cases. And over time, what we saw that when you identify the proper criteria in terms of the biological response and find the proper surrogates for that response, then you can actually have an excellent result for liver cancers with a transplant. And this started with hepatocellular carcinoma, then cholangiocarcinoma, and now with metastatic disease. So it is a specialty that is evolving, and it's a multidisciplinary specialty, not just the surgical one. So pictures from Halkidiki, which is close to Thessaloniki, about an hour away. So in terms of transplant and hepatocellular carcinoma, the advantages and the reason that we talk about is that it treats multifocal disease. You get the optimal oncological resection. It's essentially an RO resection. And it also, you kill two birds with one stone, since you also deal with cirrhosis. And essentially, that makes it the only treatment that offers definitive care. And the results in the patients undergoing transplant within the criteria that we're going to see are certainly much better in terms of the survival. Now, one of the things that we have to remember when we're talking about transplant for cancer is that these patients, their main problem is not the chronic liver disease, not the cirrhosis, it's a cancer. And so that makes it different from those patients from all the other categories, the non-oncological ones, where the reason to move faster to a transplant is the fact that the hepatic disease is progressing. They have a higher MELD score, and they're going to die. So there you have the urgency principle, whereas in the patient with cancer, it's a matter of utility. And that has significant connotations in terms of the listing of these patients, as we're going to see later. This discussion about hepatocellular carcinoma liver transplant started several decades ago, originally for extreme cases where the results were not very good, and once in a while, whether it was an incidental tumor or a smaller lesion, the results were good. And that led initially Dr. Henri Bismuth from France, and subsequently the Milan team led by Vincenzo Mazzaferro from Milan to establish the Milan criteria, where if you have one lesion less than 5 centimeters or 3 lesions All of them, none of them bigger than 3 centimeters, and there is no vascular hepatic disease, and you can get excellent results with 75% 4-year survival and a recurrence of less than 10%. Of course, the question then became, once we had established this criteria with good results, well, what if you go from 5 centimeters to 5.5? Can you do that? So that led to a gradual efforts of expansion of this criteria, with the prime example being the UCSF ones. And we see here the difference that these criteria have made in terms of the results and these patients having much better survival. Now, once you establish that, you wonder, can I extend criteria, or what constitutes a non-acceptable result for liver transplantation? Because if you're talking about a cancer patient and you know that if they get transplanted, which is a blue here, versus not, and they drop out of the list, then it's much better if they're transplanted. There is a benefit here. So that would make sense that these patients should be transplanted. However, what we have to consider is the balance of things, because every liver you use for a patient with HCC means that it's the liver that you take away from a patient with one of the other etiologies of chronic liver disease. So that means that the results should ideally be comparable between the two groups of etiologies. The other issue, the other way to adjust that and to transplant more people or to save more people is to try and use either extended criteria donors. So that means donors that would not necessarily be suitable or ideal for patients on the list because they have, for example, too much steatosis, or it's much older donor, or there has been a trauma in the donor, or there's a history of drug use, or there is an infection, and so on, or is using living donors, where the argument is, well, I'm not taking a graft from the list, the cadaveric list, but I have my own donor, which sounds reasonable. However, what one needs to think about is a situation where if there is a non-function, a primary non-function, then what do you do with that patient? So if we look at the results with carefully selected patients using the Milan criteria for hepatocellular carcinoma for transplant, we see that as long as they're within the early stages of the disease, you can get a 70% 5-year survival, which is similar to other indications for HCC. The effort to increase the criteria, we see here many of these efforts with the UCSF with bigger nodules, or other efforts where instead of the number or size of nodules, they use a total tumor volume, and so on. And essentially, that's called the metro ticket concept, where the further you want to go with the metro, the greater the price you're going to pay. And something similar here, the more patients you want to transplant, meaning the more outside the Milan criteria you want to go to include more patients, the worse the survival is going to be. So it is a matter of choice and proper allocation of grafts. In a very interesting paper where they looked at the post-transplant survival comparably, they saw that if you have a 60% 5-year survival in these patients with HCC, then that's a suitable number so that you don't harm other candidates by using the grafts for that. So the question then becomes, how do these patients get priority on the list? Because if the liver disease is not going to be significant, then they need to have another way. And that's by using essentially what's called exception points based on their stage. So people that fall within the criteria, they get exception points right off the board going on the list. And this gets reevaluated every once in a while and every few months. And we see here that this whole concept has evolved over time, and rightly so, because the needs and the allocation priorities change over time. What we do know is that you can get excellent results with liver transplant for HC when the tumor load is limited, essentially mainly based on the Milan criteria, 70% 5-year survival, and that matches post-liver transplant survival from other indications. And you always have to keep in the back of our mind, we have to keep the graft shortage, what that means in terms of the balance between the HCC patients and all the other liver recipients. The facts, and this is based on the European Association for the Study of Liver Disease meeting, so that for liver transplantation is recommended as a first-line option for HCC within the line criteria that is not suitable for resection. So that's the number one choice, and there's strong evidence for that. Now, in terms of a consensus on what expanded criteria for liver transplantation for HCC is, we do not have one. They can be considered, especially when they can be downstaged within Milan criteria, but within protocols. And finally, what we're looking for and how probably things are going to be involved are composite criteria, which means that finding surrogates of tumor biology, which could be how they're responding to chemotherapy and so on. And finally, the other undeniable factors of tumor vascularization to hepatic metastatic disease are contraindication, liver transplantation in HCC. These are from the island Santorini and Mykonos, very beautiful islands in the Aegean. Now, in terms of liver metastatic disease from colorectal cancer and liver transplantation, it is a very frequent problem and a very significant one, both because colorectal cancer is a very common malignancy, also because more than half of these patients will have distant metastatic disease at the time of diagnosis or later. And if they can be resected, you can get pretty decent results in terms of survival, but with significant recurrence. However, that's a very small percentage that can be resected right off the bat. So a very high number would go to palliative chemotherapy. And before 2000, the results were not very good with transplant, mainly because people would reach the transplant option at a very late or advanced stage. So the survival was not very good, and the recurrence was very high. What changed or started the trend towards a different mode was the second study, which came from Norway. And what the Norwegian group did in the pilot study with patients where the primary tumor had been excised, good functional status, minimum of 6 weeks of chemotherapy, and the addition of sirolimus immunosuppression protocol, what they saw is that you could get good survival results and even close 60% 5 years. However, what they did see was the disease-free survival was very low, 1 year, 35%, which means you had a high recurrence. When they looked at what factors affect this, they found the Oslo score, which is basically these 4 parameters. The largest tumor diameter, if it's more than 5.5, that's bad. If the carcinoma embryonic antigen is more than 80, if there's a short time, less than 2 years from the time of primary surgery, and if there is progressive disease by chemo. By getting 1 point for each of these, then the higher the Oslo score, the worse it is. Tosser and his group in 2017, in a group of 12 patients with strict criteria, they saw an improvement in good survival, but also significant improvement in disease-free survival in 1 year, going 56% up from 35%. And that led to the second study from Norway, which again with stricter criteria, with non-resectable, again, colorectal liver metastatic disease, but where there was a response to chemo, they saw improved not only survival, but also the disease-free survival. So that started changing things, and we saw that basically these factors here are critical. If the whole tumor volume is less than 70 cubic centimeters, if the Funk score, which we see here, is 0 to 2, and if the Oslo score is 0 to 2, and if the time of diagnosis more than 3 years, then you can have good results. And what was even more important that we saw from the second study is that although there was a high recurrence rate, the majority of these were lung metastatic disease. They were very slow to grow and did not affect survival. And these are interesting flat tables because they show you that if the metastatic disease, the pulmonary site, survival is not affected. If it's a single site, then the results are much, much better compared to when there are multiple sites. And if you just have isolated pulmonary recurrence, no matter what the number, it's still much better compared, it does not affect survival compared to if you have hepatic recurrence. And when they compared the results of the second study to the Nordic one, which used chemotherapy, they saw that there was a significant difference in terms of survival between the two groups, with the surgical group, transplant group, being far superior. Now, when one wants to compare liver transplantation for colorectal metastasis versus hepatocellular carcinoma, what was seen was that although the survival results were the same, the recurrence was much higher in the colorectal, in the liver metastatic disease group. But what was interesting was that although the recurrence was much higher, the survival in these patients that relapsed was much better compared to the patients who relapsed after transplant for HCC. Well, compared to portal vein embolization liver resection, again, the transplant group, in those patients that had a high tumor load, the survival was much better, which was also seen in a systematic review study. So overall, there is a consensus from the LTS that liver transplant can be a viable option in highly selected patients with unresectable colorectal liver metastatic disease and only liver involvement. The Oslo score is important, 0 to 2, for 5-year survival rates, minimizing immunosuppression. And when you do get recurrence, you need to treat them aggressively. For example, if it's pulmonary, go after them and resect them. Of course, the need for a registry is key. And what we need to do as next steps is to try to expand the donor pool for these patients, whether that's using extended criteria or living donors, continue improving the patient selection for the transplant, using better, more tumor-related medication for immunosuppression, such as the mTOR inhibitors, and also consider certain techniques such as rapid, which is a resection partial liver segment through transplantation with delayed total hepatectomy. So essentially, you do your resection, you transplant the left lateral segment, and then when that grows, then you remove the rest. Here is a picture of the tomb of Philip, who was the father of Alexander the Great. It was all underground, and here you can see the actual tomb, which value is that it was found untouched. And the last part is just want to mention the importance of technology in all of this. So, for example, artificial intelligence, which is based on big data, and by itself is not a sure thing because of legal, ethical issues, financial issues, but it is very important that we begin to understand and use it appropriately, because it's going to help us identify these categories of patients that can actually benefit from those treatments. Also, technologies that serve as the help show us a map of the geography, such as 3D printing, are key, and augmented reality, which can give that map inside the surgery. So in conclusion, transplant oncology does have a role in carefully selecting patients, and this is key for hepatocellular carcinoma and liver metastatic disease from colorectal cancer. Technological advances need to be fully evaluated so that the appropriate place found. And we always got to remember technology is not a substitute for technique. Thank you very much for your time. And again, congratulations to Professor Menon and the US section for this excellent webinar.
Thank you very much, Dr. Sulfich. That's a really incredible presentation of a evolving field as we really push the bounds of the use of transplantation as yet another tool in the treatment of hepatocellular carcinoma and colorectal metastases. So thank you very much for that presentation. So I think we'll go ahead and assemble our panel now, including yourself, of course, Dr. Solfus, but also we're going to go ahead and bring Dr. Beppu and Dr. Cummings. I need to briefly introduce Dr. Cummings, who's going to be joining us as a panelist. Dr. Cummings is also an expert in hepatic surgery. He attended medical school at St. George's University School of Medicine, did his general surgery training at Maimonides Medical Center in New York City, and then his training culminated at Georgetown University, where he completed a fellowship in abdominal organ transplantation and hepatobiliary surgery. He's a clinical assistant professor at the University of Missouri, Kansas City, and is on staff at the St. Luke's Hospital in Kansas City, who's part of the liver disease management and liver transplant teams. So thank you and welcome, Dr. Cummings, for joining us to discuss these complex oncologic issues. So I'll go ahead and start with the first question, and perhaps I'll have each of the panel address this question. But I'll start with Dr. Beppu because you mentioned ALPS as a strategy rather than just a two-stage traditional hepatectomy. So how do you decide which patients will have the ALPS technique versus the traditional two-stage hepatectomy?
And I think an ALPS is the only one of the options. And ALPS is recommended for limited patients with too small future remnant liver, 20% or smaller, and salvage ALPS for patients with insufficient liver regeneration after PVE or two-stage hepatectomy.
Great. So it's most extreme cases where okay. Dr. Solfus, do you use ALPS as a technique as well, and how do you make that decision? I think you might be muted, or we can't hear your audio at the moment, Dr. Solfus. It seems like we're still having an audio issue there. Well, we will come back to you in a moment and go to Dr. Cummings. Do you use ALPS as a technique? And
thank you for the opportunity to be part of the panel. Admittedly, that's not something that we typically use. If you look across the United States, I think that it certainly needs to be done more. But currently, we don't use ALPS routinely. I think most of the community still tends to focus on using whole organ embolization as a bridge for resection for patients who have a small FLR or utilize peripheral sparing techniques. But I do think it's something that needs to be sort of advanced in the United States and certainly in our group.
Yeah, and perhaps an opportunity for kind of some collaboration as well. That's interesting that there's a variation on the techniques that we use across countries.
Yeah.
Well, yeah, no, that's a very interesting.
I think if you look at transplantation, go ahead. I'll wait.
No, go ahead. Please continue to expound.
No, I was quite impressed with the presentations. If you look at as someone who does liver transplant and resection for colorectal metastases, the recurrence rate for primary resection is quite high. And so I think if you look at liver transplantation, I think for patients with biliary disease where most of the liver is replaced by tumors, it certainly makes sense. But we're still sort of limited by the organ shortage. But I do agree that it's a step forward for many of our patients who particularly have a long disease-free survival and have shown response to chemotherapy and are relatively stable. I think it's a great option.
Dr. Solfus, we'll try to bring you in. Is there audio? Gosh, for some reason, I still was not able to hear you. Let's see. Oh, and it's muted right now. The mute button is on. If you could unmute.
How about now? Is that
Oh, yes, perfect.
Perfect.
Yeah.
Okay. Sorry about that.
No.
So it's an excellent question with the ALPS, and I agree with both Dr. Beppu and Dr. Cummings. And I think the way to approach it is one part of the armamentarium that we have for the small volume cases. As much as surgeons we may like the ALPS, it's still not the golden standard. That remains the portal vein embolization and the slower route to things. But I think as more experience is gained with ALPS and even with the laparoscopic elements added, I think there is a lot there to it.
Great. Thank you, Dr. Solfus. I'm going to go back to Dr. Beppu again, I'm intrigued by the Beppu score, which is used for prognostication. Is there a different scoring system that you use after chemotherapy has been administered, after you're able to evaluate the response? Do you rescore with the Beppu score, or do you use a different scoring system to provide prognosis?
Okay. BEP score is built by for upfront hepatectomy. So, and pre-operative cases, BEP score is had a little bit lower impact. So we use and risk scores from Paul Booth for conversion and nomogram for conversion hepatectomy.
Okay, great. Thank you. Dr. Cummings, what do you use to help predict prognosis after neoadjuvant therapy?
Typically, we use radiology criteria, looking at tumor response to treatment. If we do pre-op treatment, typically nowadays we do very few upfront liver resections for patients with metastatic colon cancer. Certainly, there's an increasing role for oligometastatic disease after adjuvant therapy, but most patients who present now with metastatic colorectal cancer get pre-op chemotherapy, and thereafter we assess their treatment response based on size of the tumor, CDA, there's typical standard factors. We don't have a Beckley score, but like you, I am somewhat intrigued by being able to utilize it to find some of those patients who may be upfront surgical candidates. So long story short, we still use pre-op chemotherapy, see their response, and then make a decision not to chemo coverage thereafter.
Thank you. And Dr. Solfus, which scoring systems do you use for upfront surgery or for after neoadjuvant?
We use the FONG score, but the problem is, I think the main key here, and I think the key issue with this very important question, is the biological behavior of the tumor that we just cannot predict. We have all these indirect ways, whether it's a different scores, some of them better than others. They also depend on the local population sometimes, but it's all of these are indirect ways to identify which patients will do better, or which will respond to chemotherapy, which have a chance, which ones you should push. And especially when it comes down to transplant, it's the same question, which ones you should go ahead, because the harder thing with transplant is that you're not just endangering the life, the specific patient, but you're using something, the graft that you're taking away from someone else, potentially. Unless we go to the more extended criteria grafts, that's the issue there. But I think the big question is the biological behavior, and that's, it's the usual, not the usual, but the saying that biology is king and queen, and the surgeons are princes, and once in a while surgical prowess will win the day, but it's just a day, because it will come back to bite you.
Absolutely.
I agree. I was about to say the same thing. Biology is king. And I think a lot of it is just, we have various scores that are somewhat helpful, but is that following that lead and see how they're doing radiologically and based on labs is what we could use. Yeah.
Dr. Solfus, I particularly liked how you highlighted that the goal of therapy, neoadjuvant therapy, or maybe it was Dr. Beppu who highlighted that the goal is not getting to resection, but the goal is overall survival. And perhaps it was Dr. Beppu that kind of emphasized that. Really, it's overall survival that matters, not the ability to ultimately resect. So yeah, biology ultimately leading to survival really being the key. Dr. Solfus, I was also, to go a little bit deeper into the question of transplantation. Certainly, as we continue to move the field further and along on transplantation, what do you think that the next concrete steps that are needed to further advance the opportunities for individuals to have access to transplantation if they have high volume liver disease from colorectal metastases?
I think the key is, first of all, establishing the right criteria, meaning which patients should be transplanted, identify that group of patients that should be transplanted. That's number one. And the other issue is identifying the grafts that can and should be used there. So when they looked into things with cholangiocarcinoma, which was also not as standard as hepatocellular carcinoma in terms of an indication, they identified that as long as you can achieve a 5-year, 60% survival using a Markov model, then you're not, quote unquote, stealing away grafts from other etiologies. So that's the standard that we have to go after with the colorectal liver mets. Now, to identify the group of patients, we need in the beginning very strict criteria. And the majority of them, whether it's a time from the initial resection or whether it's the existence of other metastatic disease, again, refers to the biological behavior. In terms of the liver graft to be used, the key here is that these patients don't have cirrhosis. So you don't have a patient with a high MELD score who needs an excellent quality graft. So a lot of grafts that are not used for the higher MELD patients can potentially be used in these cases. Now, again, this depends on the criteria, on the national criteria. In Europe, where the system is a little bit more liberal in terms of we use the MELD score, but it's more center oriented. You do have that potential to use grafts that would otherwise go to waste.
Sure. Dr. Beppu, is there a move in Japan to use transplantation for liver metastases?
I'm very interested in liver transplantation for advanced bilobar colorectal liver mets. But living donor liver transplantation occupies the majority in Japan, and it's not covered by health insurance. So a clinical trial had just started for liver-only colorectal liver mets other than progressive disease by chemotherapy had just started. And the primary endpoint is a 3-year over survival. And so I know, and it is liver transplantation is not in my hand.
Sure. But I'm very impressed that it's being studied so rigorously as part of a clinical trial.
Yeah.
That's very impressive that it's being studied so so deeply. That's fantastic.
Thank you.
Dr. Mann, if I can jump in, I think Dr. Bepp raised an excellent point here with the living donor, which Japan is a country that has excellent, one of the top experiences worldwide with living donors. And it is a key question whether you can, of course, but whether using living donors for these patients. And one of the U.S. Side experiences is a group from the University of Rochester, led by the team and others in a multi-center trial, which did use living donors as well. It gives you the freedom to plan things in a much more organized manner. The problem is, because a living donor is the most precious patient in the hospital, if you have a non-function, if you exceed criteria, then what do you do with that recipient? Do they go back on the list? That's a question. So it's really a key point, what Dr. Bepp mentioned.
No, it certainly resolves some of the ethical issues and creates perhaps new ethical issues. So that's
well, I would just add and agree with Dr. Sopas that in the marginal grafts, I think, are a potential source for these type of patients. I had an offer yesterday where it was a 75-year-old donor with hemochromatosis, and the liver was probably usable. A little bit of iron, a little bit of fibrosis, but that liver would have been fine in somebody with this type of problem. And those type of offers happen every day. So I think that's a good source, I think, for these kind of patients in the future.
Yeah. So the key here is protocols, making sure that we have, center communication and things happen in a protocol so that we can see what works and what doesn't work.
Exactly.
Well, I want to thank our panelists and speakers, Dr. Solfus, Dr. Beppu, Dr. Cummings. Thank you very much for your time. As it always happens, as we're getting into the deeper part of the discussions, we end up having to finish. I particularly want to thank Dr. Solfus and Dr. Beppu because I know that the time zones make this experience very challenging. So thank you for being so gracious and being willing to join us at odd times of the day. So I appreciate
I just want to congratulate you, Dr. Naiman, and the U.S. section for organizing, and Dr. Amatori, which I see here, an excellent webinar on a very important topic. But congratulations. It's never an easy thing, and especially organizing it globally. So congratulations.
Well,
Thank you very much for everyone. Nice
Thank
webinar.
you. Thank you very much.
Well, I'm going to hand it back to Dr. Amajoya, who's our executive producer, and to perhaps close us out and tell us about the next event.
Yes, thank you, Dr. Mammon. This was an excellent webinar, especially being a colorectal surgeons, and obviously we deal with the colorectal cancer, and oftentimes up to 50% of the time our patients will have metastasis, and we definitely need the hepatic surgeons to get involved. So I learned quite a lot today. I learned about the Beppu score, and that's something I have to look into a little bit more. But thanks, Dr. Mammon, and thanks to the speakers, Dr. Cummings, who's here in Kansas City, and Dr. Beppu, and Dr. Sofers, coming from all the way from Japan and Greece, respectively. I appreciate you guys. Special thanks to our planning team and the ICS-US family. We hope our listeners will join us next time and become a part of this great community by going to the website on the screen that you can see there. So by going to our website, ficsonline.org, to join us and register for the next webinars. The next webinar will be on rural surgical emergencies, and it will be on July 29th, 2023. So 2 months from now. Again, I am your host, the executive producer, Dr. Rob Amajoy. Until next time.